Hi, good morning, everybody, and or good time of the day wherever you are in the world. And thank you for joining us for the third session of the 2023-2024 ISPD Virtual Education Series, which is made possible thanks to the support of the ISPD Corporate Council. My name is Tim van Miechem, and I'll be moderating today's webinar, which is focused on fetal hydrops and pleural effusions. And we will hear from Drs. Teresa Sparks and Nimrah Abbasi with talks focusing on the genetics of fetal hydrops and prenatal treatment of pleural effusions. Now, before we get started with the actual presentations, I do have a few announcements to share for housekeeping to facilitate running this webinar. So first of all, if you need technical assistance, please use the chat function for support, and we will try to help you getting everything organized. Know also that closed captions are available in English if you have difficulties understanding the speakers. Throughout the presentation, you can also submit questions for the presenters, which we will address in at the end of both presentations during a Q&A session. And so please submit the questions not through the chat function, but through the Q&A function, so that they're all organized together and that we don't miss any questions at the end. Using that Q&A function, you can also upvote questions which you like to see addressed, and rather than repeating questions that other attendees have asked, please add a thumbs up so that we know that these questions are important and that we make sure that we get to those questions. You can also raise your hand to ask a question during the live session, but know that the event is being recorded, and if you don't want to be recorded, that you should not raise your hand to speak or submit a question in the Q&A box. Good. So that all being said, I'm really happy to introduce our first speaker for today, who will speak on the genetics of fetal hydrops. And we have the expert in the field for that, Dr. Teresa Sparks. Dr. Sparks is a physician who specializes in both maternal fetal medicine and clinical genetics at the Prenatal Diagnosis Center and the Fetal Treatment Center at UCSF. She's also the program director for the Maternal Fetal Medicine Fellowship there and the co-director of the Women's Reproductive Health Research and K-12 program at UCSF. She's passionate about research and a Chan Zuckerberg Biohub investigator, as well as an investigator for the UCSF Center for Maternal Fetal Precision Medicine. She's published extensively, including in our affiliated journal Prenatal Diagnosis, on the approach to care for non-immune hydrops and other fetal anomalies by establishing multi-center collaborations and gathering data, performing genomic sequencing on those populations to really discover the breadth of underlying causes of fetal hydrops, and refining clinical testing algorithms and developing novel in utero treatments from these disorders. So who better to speak on fetal hydrops than Dr. Sparks? Please, Teresa, take it away. You have the floor.
Thank you so much for the kind introduction and for the opportunity to speak today. It's really an honor. Just bear with me for a moment while I share my screen. Okay, just confirming that everybody can see this.
Yes, we can see your screen really well and we hear you well.
Thank you. And just to preface, I still am getting over a little bit of a cold, and so if I pause for a moment, then I will come right back. I'm just still a little bit short of breath with the longer talks, but bear with me. So again, thank you so much for the opportunity to speak today. It really is so much fun to be able to talk about this topic. And to be able to gather information from others. I find it really interesting too with the questions at the end, with the information and the questions that I get from other people, because it really helps push the science forward. I have no disclosures. And so with hydrops, I think most people in the room, in the virtual room, I should say, are familiar with hydrops. And so we know that this is diagnosed in the setting of abnormal effusions that are seen in a fetus that are typically diagnosed on a routine ultrasound. There are immune and non-immune subtypes, and we are, for the purpose of this talk, going to focus on the non-immune subtypes, and in particular, the genetic etiologies of non-immune subtypes. It's been really fascinating over the last few years. There are hundreds of genetic disorders that have been suggested to be associated with the development of non-immune hydrops and fetal effusions. And I think it will be fascinating over the coming years as next generation sequencing becomes more and more applied in the prenatal setting to see what we continue to learn about the genetic underpinnings of non-immune hydrops. And not to discount the other types of etiologies that can lead to hydrops. We all know, of course, that there are many viruses that can lead to hydrops, and of course, alloimmunization and twin-twin transfusion syndrome and all kinds of other things can lead to a similar phenotype on ultrasound, but we're going to focus again on the genetic underpinnings of non-immune hydrops. Often there is a grim prognosis in the setting of non-immune hydrops, but as we will talk about over the course of the presentation, one of the really important things that we can do as providers in the prenatal space is do our best to understand what the underlying etiology is and tailor our expectations for the patient and the family that's in front of us based on the underlying diagnosis, because it can differ from one to the next. In terms of the spectrum of fetal effusions, this is another area that I think is really fascinating with what we are starting to understand about hydrops and fetal effusions. Again, hydrops is diagnosed when there are two or more effusions, but single effusions are also really important to understand. And I think we will probably get into this too with the next talk. But single effusions can evolve into hydrops, but what's really important to understand about single effusions, like an isolated pleural effusion, is that many of the same genetic diseases can cause an isolated pleural effusion as compared to hydrops. And it's really fascinating to think about why, the same genetic disorder, the same genetic mutation can lead to perhaps an isolated effusion in one fetus as compared to florid hydrops in another. And as we are applying next generation sequencing and when I say that term, I'm referring to exome and genome sequencing or gene panels primarily, which are the more common things that are sent to identify single gene disorders in the prenatal space. As we are applying that testing more broadly, we are starting to see patterns in terms of fetal effusions with different disease categories. And so we'll get into this a little bit more with the talk, but for example, RASopathies tend to present early on, as we all probably know, in the setting of cystic hygroma or a big nuchal translucency. And when they present with hydrops or single effusions later in the pregnancy, tend to be more often pleural effusions or skin edema. And, disorders like inborn errors of metabolism may present more often with ascites. And there's some really interesting patterns that are starting to emerge with the fetal effusions. And so, excuse me. This is my analogy that I like to use when I talk about hydrops, because if you imagine in the circle here that this is a fetus with hydrops on ultrasound, there are a lot of different roads that can get to that same path. And so this is sort of the way that I think about hydrops is, it looks similar on the ultrasound when we all arrive at the same place for different reasons. But I think there's a lot of underlying clues that we can start to understand about the fetus that's in front of us as we're scanning and trying to pinpoint the underlying etiology. And those differences may be in additional things like concurrent anomalies that the fetus may have. It may be in things like timing of the onset of effusions. It may be the types of effusions like we were talking about on the prior slide, and other such factors. So in terms of what we know about the genetic testing that we have available and what we can use to identify an explanation for non-immune hydrops, historically, as we all know, we've used karyotype for a long time, and then microarray, really over the last decade plus in the setting of prenatal diagnosis. And the karyotype is certainly an important test as a first-line test when we are thinking about the reason for hydrops that's in front of us. Some places use qF-PCR as an alternative. And with microarray, we'll talk about this over the next couple of slides, but it has been interesting to see as the data has come out over the last few years about copy number variants. And it's interesting because there certainly are copy number variants that are identified in the prenatal space with hydrops, but very few that seem directly related as an explanation for the hydrops. And so one study, so we published this study a few years ago, and I like to give this example because I think it's really important to think deeply, right, when we're all scanning these patients that are in front of us that are so complicated. And so what we did with this study is we looked at data through the UC Fetal Maternal Consortium, which is a collaboration between many of the University of California sites in California. So we looked back at cases of hydrops within that consortium and asked the question, was there a confirmed etiology or a suspected etiology of the hydrops, or was the etiology just unknown? And what I like to highlight with this is that in 45% of the cases, as you can see in that confirmed category, some of these cases had a genetic explanation like Turner syndrome or Down syndrome. Other cases had a structural abnormality, which is important and mechanistically may lead to the hydrops as well. But what's important also to think about is what's the reason that, for example, the CDH is there? And is there a genetic explanation for the CDH and thus the hydrops? And how can we delve a little bit deeper to really understand the abnormality that's in front of us, and in particular, inform the family about recurrence risk for the future? This slide I put in here just to give people a little bit of a sense of the yield of different tests. And we don't have to go into all of the specifics here, but this was a nice study that was published a couple of years ago, looking at a relatively large number of patients in China. And they did sequential testing for fetuses that presented with non-immune hydrops. And so overall, in their cohort of 109 patients, 19% had an abnormal result of QFPCR or karyotype. And these were largely, as one might expect, Turner syndrome, trisomy 21, and trisomy 18. And for those patients that then did not have an explanation, they were then offered a microarray. And of the 72 patients that then had a microarray, 4% of them had a pathogenic or likely pathogenic copy number variant that was identified on the microarray. I think what is important to note, though, is that when you look at the copy number variants, and I put an example here of 22q11 duplication syndrome, certainly is a pathogenic duplication, but I think the bigger question is, does it explain the hydrops? And I think for a lot of these copy number variants, we don't know, and it may not actually explain the hydrops. And then in 21 patients that then did not have an explanation with any of the preliminary tests, they opted to move forward with exome sequencing. And among those, 3 or 14% of those had a diagnostic result. And we'll look at more data with some other studies about the diagnostic yield of exome sequencing. And I put the variants here, but this really just gives a sense of the big picture of, aneuploidy is certainly a common etiology of hydrops. Copy number variants we can identify, but it's a little bit up in the air about whether those are actually the explanation for the hydrops. And then exome sequencing certainly is important, as we'll talk about. I also put this slide in here to emphasize one of the points that I made on the last slide, which is that this is a series that we published from our center looking back at 10 years of hydrops cases. And the take-home point with this is we were trying to understand what is the incremental yield of microarray over karyotype for cases of hydrops. Overall, in our cohort, 10% of cases of hydrops had aneuploidy as the explanation, so varies from cohort to cohort. We remember it was 19% with the prior study. But importantly, among the 44 patients that had a microarray as well, there were not any copy number variants identified that were felt to provide an explanation for the hydrops. And so this leads us then to talk about exome and genome sequencing, which I think is such a fascinating area of research right now that has really taken off in the last few years. And so what we know based on exome and genome sequencing studies that are emerging in the literature is that these tests can be really helpful for fetal anomalies. And it's interesting to see the variation across different fetal phenotypes. I'm just catching my breath for a moment. So, for example, we know that there are some types of fetal anomalies where the diagnostic yield is a little bit lower. And that can include, for example, some of the genitourinary anomalies. And in contrast, there are other fetal anomalies that tend to be higher in diagnostic yield. And examples of those are things like skeletal dysplasias, and as we have learned, hydrops. And I think most people that are joining in are probably familiar with these testing methodologies, but just to say it out loud, with exome sequencing, we're focused on, you can see here, the coding regions of the genome. And so this is where most of the currently known disease in humans originates, but we have lots to learn about the non-coding regions. This encompasses over 20,000 genes, but is still a really small proportion of the genome. And so exome sequencing is very helpful because, again, it's most of the exons are where most of the genetic variants are that we know in association with disease, but there's a huge part of the genome that's outside of that is not captured by exome sequencing. And so that's where genome sequencing comes in, where we're addressing those non-coding regions in the near entirety of the genome. With the hope there being that adds detection of small copy number variants, perhaps those that are smaller on microarray, larger structural rearrangements. And it's been interesting, and I will be very interested to see the data that continues to come out about genome sequencing for fetal anomalies. So far, it seems like the incremental yield has been a little bit smaller than I think many people had hoped. And I would say in our experience, we've been offering genome sequencing at our center for all cases of fetal anomalies for the past year. The biggest advantage really has been the turnaround time, because we are able to get the results of genome sequencing back much faster for our patients than we were able to do with exome sequencing. And so I'm going to go over some of the work that our group published a couple of years ago, and then we'll go through some other studies that exist in the literature and some cases, which I hope will illustrate some of the points we talked about. With this study, what we did is, over the course of 3 years, we enrolled cases across the country with fetal effusions. So we cast a broad net, with the reason being one that we talked about earlier in this presentation, which is that we know increasingly more that the genetic underpinnings of fetal effusions, whether that's a cystic hygroma or a single effusion or hydrops, are similar, and there's a lot of overlap. And it's really important to understand how these diseases present in the fetal period. We took cases that had non-diagnostic results of karyotype or microarray, and again, recruited nationally in the United States with the hopes of casting a broad net. And it was fascinating, I think, to see the breadth of etiologies. And so we ended up enrolling, as you can see here, 127 patients. And among those, 37% had a diagnostic, or 29%, excuse me, had a diagnostic variant, or 37 patients. And you can see in the pie graph that's over here that RAS apathies were the largest proportion. So there we're talking about diagnoses like Noonan syndrome or Costello syndrome or cardiofaciocutaneous syndrome. And this, makes sense with what had been published in the literature before, although perhaps was more than we had anticipated. And interestingly, inborn errors of metabolism, I will say, was less than I had anticipated going into doing this study, but certainly an important diagnosis to make. And then you'll see here that there's a wide breadth in terms of other etiologies, from lymphatic disorders to hematologic and immunologic, and it really is a very broad range of diseases that were identified. And what remains open and for a lot of research to further understand is what the pathophysiology is that leads to the hydrops in these cases. Here I put some examples of some of the specific diagnoses that we made. So these are among those 37 patients that had a diagnostic variant or variants that were identified. So you can see here that we had several cases of Noonan and Costello syndrome. For the inborn errors of metabolism, we saw GM1 gangliosidosis and mucopolysaccharidosis type 7. Then we continue down, we see some of the lymphatic disorders like Milroy disease, ciliary disorders, some interesting ones like Charge syndrome, where, this case I found interesting, which is it was clearly a diagnostic variant and a clearly pathogenic variant. But I think the biggest question with that is this the explanation for the hydrops, and what is the pathophysiology, and does this explain what we're seeing on the ultrasound? Another piece that's really important to highlight is this, which is over here, where we again have only been applying next generation sequencing in the fetal space for a relatively small number of years when we think about it. And so there's a lot about fetal disease and genetic variants that cause fetal disease that we have yet to better understand. And so at the time when we published this data, 58% of the variants were novel and had not previously been reported. Now, thinking a little bit, now this is what I was talking about a little bit earlier, where we're starting to understand more about the phenotype that's in front of us and think critically about what do we think is the diagnostic yield and what do we think the underlying diagnosis could be. When we broke it down by types of fetal effusion, you can see here that for cases with an increased nuchal translucency or a cystic hygroma, overall the diagnostic yield with exome sequencing was 31%. I will note that for cases that were isolated, so they just had an increased nuchal translucency or a cystic hygroma with no other effusions, no other concurrent anomalies, the diagnostic yield for those cases was 7%. And so this number here was largely driven by the cases that had another fetal effusion or a concurrent anomaly. Now, cases that had a single fetal effusion, like I put here in the picture with perhaps bilateral pleural effusions, but no ascites or no skin edema, the diagnostic yield for those cases was 10%. So certainly lower than for example, the greater than 2 fetal effusions category, but not insignificant. And many of these diagnoses are really important to make. And then the cases that had 2 or more fetal effusions, the diagnostic yield was 34%. I think many people on the call are familiar with how important a prenatal diagnosis is, but I really like to emphasize this in the talks, and it's what I think about when I have a patient in front of me that has hydrops, which is certainly this is concerning and very worrisome, and we worry about the prognosis for both the fetus and the pregnant individual, given the risk of preeclampsia and Mirror syndrome and other complications. But what can we tell them about what to expect after birth for those that continue their pregnancies? And I give the examples here of diagnoses like Noonan syndrome or mucopolysaccharidosis type 7 or Diamond-Blackfan anemia, which we all know, and these have been published in association with hydrops. But if those fetuses, neonates survive past that rocky neonatal course with hydrops, we would expect the outcomes to be quite different for these diagnoses. And so, again, thinking of that patient that's sitting in front of us when we are trying to estimate things like survival or developmental delay or comorbidities, and especially quality of life, which is one of the things that's so important to our patients, the more accurate we can be with an underlying diagnosis and explanation, the better. And another thing, just to make sure that I say this as well, that I think is really important when we are doing this is that one area of research that we really need more of is to understand what the outcomes are for a fetus that presents with Noonan syndrome as compared to, for example, a child that is diagnosed with Noonan syndrome with maybe the same genetic variant, but we don't really have good data about whether, that child with the same genetic variant, what outcomes are as compared to a fetus with the same variant that presents more severely in utero with hydrops. We don't have great data on neurodevelopmental outcomes, for example, and other long-term outcomes to be able to tell our families with certainty. So it's an area that I highlight that I think is a really important area that we need more research to be able to accurately guide our patients. I think I actually covered a lot of this on the prior slide, but just to say out loud too, that making a diagnosis is hugely important for our families that want this information. It can, in some cases, alter the way that we approach antenatal management. And so this can include things like being able to offer families consultations with services that are appropriate, that they will be engaged with after birth, for example, pediatric neurology or pediatric cardiology. It can allow us to make nuanced decisions with our patients if we have a really grim prognosis and a really challenging genetic diagnosis for a fetus with hydrops. We can be thoughtful about the way that we approach surveillance during that pregnancy with ultrasound or antenatal testing. It can affect the way that we counsel and make decisions with our patients about mode of delivery. And it allows us also to be able to make plans for prompt neonatal treatment for situations where, for example, enzyme replacement therapy is important to initiate on the earlier side in order to improve outcomes. So there's huge advantages to making this diagnosis early. Okay, so I have a couple of cases here that we can go through, which hopefully highlight, again, some of the breadth of the genetic diagnoses, but also some of the challenges that we have when we make some of these genetic diagnoses. So this first case is a more straightforward example of a genetic diagnosis that we see with hydrops. So this patient was a 29, excuse me, 29-year-old G4P2 who had two healthy children, one prior miscarriage. She had had an uncomplicated start to her pregnancy with low-risk cell-free fetal DNA. And at 20 weeks, presented to us with polyhydramnios, clenched hands, as you see in the pictures here that are on the right side, as well as a small to absent fetal stomach. She elected to have diagnostic testing with a microarray, but didn't want any further testing quite yet at that time in her pregnancy. The pregnancy continued forward, and as you can see here, by 28 weeks when she came back to see us, there was marked polyhydramnios with an AFI of 57. There were again the clenched hands with a fixed adducted position of the thumbs. There was skin edema primarily on the head, and many other features that are listed here, like macroglossia, retrognathia, dysplastic and low-set ears, and intermittent arrhythmia in the fetus, small to absent stomach, relative macrocephaly and a large abdominal circumference, and relatively shorter long bones, as well as pedal edema. So a lot of things that we're looking at on the ultrasound. As you see here, I'm just moving the picture so that way I can see the biometry. So at that time, she was 28 weeks and 3 days, as you see at the top of the ultrasound here. The fetus was measuring 30 weeks and 4 days. And you'll note here that many of the parameters are bigger than we would expect at 28 weeks. And so you see, for example, the BPD and the head circumference that are a few weeks ahead of what we would expect. And in particular, the abdominal circumference was several weeks ahead of what we would expect with no ascites. So presumably organomegaly or other causes in this situation. The patient was admitted for preterm contractions, had an amnioreduction, and at that point, she did want to move forward with exome sequencing. She ultimately was delivered at 32 weeks in the setting of preeclampsia with severe features. I put some more pictures here because I think the pictures are really important to tell the story. You see, again, the clenched hands here that we were talking about, some concern about the fetal profile as we discussed on the prior slide, and then the pedal edema that you see here. These pictures here show the low-set ears that were thought to be dysplastic, the abdominal circumference where we see the absence of the stomach bubble, and again, the fetal profile. And so the exome sequencing in this case returned with a heterozygous pathogenic missense variant in HRAS. And HRAS, we know a good amount about. It is one of the genes that is associated with the retinopathies, and in particular with Costello syndrome. This particular variant that we saw in the fetus is the most common variant reported in Costello syndrome cases, so there's a lot known about it. This variant was de novo, had strong gene and variant disease association, and really makes sense with what we know about the retinopathies in a fetus. And we're going to talk a little bit more about the retinopathies in a few slides, but I put some of the features of the postnatal features of Costello syndrome here just to think about. And of course, many of these are not possible for us to see in the prenatal setting, but some of them are. And so things like relative macrocephaly is often one of the presenting features with retinopathies, low-set ears. We didn't see any cardiac defects, but we did see arrhythmia in this fetus. And of course, some of these other features are going to be really challenging for us to make a diagnosis of in the prenatal space, but there is overlap certainly with some of the postnatal features. And we'll talk about some of the unique fetal features of retinopathies again in a few slides. But the point of this case is that this diagnosis made a lot of sense with what we know about the retinopathies and really seemed to be an explanation for what has happened in this fetus. The next two cases, I illustrate a little bit less certainty where, we certainly need more research again, as I was alluding to before about the pathophysiology. With this case, this was a really interesting one. So it was a 37-year-old G3P0 who at 12 weeks had a cystic hygroma as well as skin edema and a pericardial effusion. There was a thick nuchal fold later in the pregnancy, but the earlier effusions that had been seen in the cystic hygroma resolved. There was also a single umbilical artery, and she elected around the time of her anatomy scan to move forward with amniocentesis for a microarray, which returned normal. And I just noted her comorbidities here, which include gestational diabetes, chronic hypertension, and obesity. Now, exome sequencing was later sent for her, it was a few weeks after that. And mostly actually because that earlier phenotype, even though it had improved, was bothersome, and the patient decided that she wanted more information. And so for this case, there was a de novo heterozygous pathogenic frame shift variant identified in RPL11, which is associated with Diamond-Blackfan anemia. Diamond-Blackfan anemia is an autosomal dominant disorder that's associated with the features that you see listed here, which are red blood cell aplasia, normochromic macrocytic anemia, reticulocytopenia, growth restriction, and malformations of a number of different systems potentially. And again, there's variability from one person to the next. At the time that we found this, there were certainly case reports of non-immune hydrops with Diamond-Blackfan, but this particular variant was novel. And again, really an interesting presentation with resolution of the fetal effusions. And so now knowing this diagnosis of Diamond-Blackfan anemia and thinking that there could be risk for fetal anemia, this was a patient that had been referred to us by an outside team. Her local team continued to manage her and did MCA Dopplers for surveillance to understand if there was risk of fetal anemia. And this really was quite variable in terms of the MCA Doppler measurements that they got back, both as you can see here, the multiples of the median ranging from 1.3 to 2.1. The local team had considered APUBs in the setting of these elevated MCA Dopplers, but her high body mass index and posterior placenta unfortunately precluded completion of the procedure. That being said, even though that wasn't able to be done, they were able to arrange for prenatal consultations with NICU as well as with hematology and made appropriate plans for delivery, having the advantage of knowing the diagnosis in the fetus before delivery. Again, what I think was really interesting for this case, and she had these intermittently elevated MCA Dopplers, but there was recurrence of fetal effusions that had previously resolved. And so she ultimately was delivered via C-section at 32 weeks after the scalp edema recurred. And there was also polyhydramnios at that time. And that fetus had a nearly 2-month NICU course, but was ultimately discharged. And I would say, again, one of the huge advantages of knowing the diagnosis was the ability to change the surveillance plan during a pregnancy and to prepare the family for what to expect after birth for this fetus and child. And this last case, I think, illustrates the most ambiguity out of all of these. Now, this was a 35-year-old G1 who at 17 weeks had an ultrasound that showed a right pleural effusion, skin edema, and heterogeneous lung parenchyma that was suspicious for pulmonary lymphangiectasia. At 20 weeks, there was resolution of the pleural effusion, but there was still some skin edema, and the nuchal fold was 7.5, so it was elevated. The local team for this patient had done an MRI in the setting of the concern for pulmonary lymphangiectasia, which at that early point in the pregnancy was read as normal. And the patient did elect for an amniocentesis, which was done and returned with a normal microarray. And she did elect to proceed with exome sequencing at that point. The exome sequencing showed a de novo heterozygous, likely pathogenic frame shift variant in a gene called SUS12. SUS12 is associated with the syndrome that you see here, Imagawa-Matsumoto syndrome, which is an emerging autosomal dominant disorder that's associated with these features, many of which we cannot pick up in utero. And so developmental delay, postnatal overgrowth, some of the subtle dysmorphic facial features. It can be associated with anomalies of some of these systems, which we'll talk about over the next slide in terms of the central nervous system. But at this time, we had really limited information about what to tell the family in terms of expectations for after birth. There were 3 publications at the time that described 13 children with very limited prenatal information about how the ultrasounds had looked in utero for them. And, really the biggest question in our mind for this case was, is this a phenotype expansion? Is this particular syndrome associated with hydrops and it can present with hydrops, and perhaps we just didn't know that before? Or was this an unrelated incidental finding that we just happened to find, and the reason for the hydrops and the fetal effusions still remains unexplained? And I think the question is still out on that one. So I think, hopefully these cases give you a sense that there are some diagnoses that we understand better in association with hydrops and really make sense when we get those results back on exome or genome sequencing or gene panel. And there are others where we have a lot to learn to really understand whether that's a true relationship, what the risk is of hydrops or fetal effusions with that diagnosis, or whether it's an incidental finding. And this is just an example of a patient that unfortunately had more than one disease process happening. And then just for a little bit of follow-up on this last case, they ended up repeating the MRI, which showed resolution of the skin edema at 26 weeks. And they did identify an asymmetric gyral pattern in the left superior parietal lobe that was concerning for polymicrogyria. This patient was able to have a consultation with pediatric neurology, and preparations were made for delivery. She ultimately PPROM'd at 36 weeks and was delivered vaginally, and then has been since followed by pediatric neurology with some of the features that are consistent with the diagnosis of Imagawa-Matsumoto syndrome and some seizure activity, unfortunately. So I put in here, there's so many papers that have been published over the last few years, which is really exciting to see with respect to the diagnostic yield of exome in particular for hydrops. And there's a couple of there's actually many systematic reviews that have been published. I'm going to focus a little bit more on original data for the purpose of this presentation, but I put these systematic reviews in just to sort of give an overview of what has been published so far. This one was published a couple of years ago that looked at overall the diagnostic yield of exome sequencing for cases of non-immune hydrops. As we might expect, based on some of the data we looked at earlier, about a third of the cases were the result of RAS apathies. And then, similarly, as we might expect, for isolated cases of non-immune hydrops with no structural anomalies associated, the diagnostic yield was 24% as compared to 38% for cases of non-immune hydrops with structural anomalies concurrently. And then this was a systematic review that was published looking overall among the single gene disorders at the breakdown of different categories, which actually is consistent across studies, and is a way to sort of categorize in our minds for those cases that have normal results of karyotype and microarray. Then if we apply exome or genome sequencing or gene panel, what might we find and what's the chance of these different categories? So one of the things that we think about with our approach to the diagnostic evaluation in cases of hydrops is, should we send a panel or should we send exome or genome sequencing? And the challenge for us in the United States is that access to exome and genome sequencing is difficult, and can at this point largely be accessed through research studies at academic institutions. Gene panels, in contrast, are more often covered by insurance and can be more accessible to the general population. But there's limitations in our knowledge. And so what we did is we looked with the study that I had presented that our group had done a few years back. What we did is we took the diagnoses that we made by exome sequencing, and we looked back at the genes included on available gene panels and said, well, if we had instead used a gene panel, how often would we have picked up the diagnosis that we already know about? And so as you can see here, for non-immune hydrops panels, we would have made a diagnosis in about, skipped ahead before I was ready. We would have made a diagnosis in about 2/3 of cases. This, I put the asterisk here because it was interesting while we were working on writing this paper, one of the labs that offers one of these non-immune hydrops panels updated their panel to include the genes that we published in our paper. And so the yield started as 2/3 if we had used that panel, and then all of a sudden jumped to 100% when they added those. But it just goes to show that we're learning and we're updating panels and we're continuing to move science forward. In comparison, if we had used a metabolic panel, we would have identified a really small proportion of cases because that's focused primarily on inborn errors of metabolism. And if we had used a RASopathy panel, we would have identified about a third of cases, which makes sense based on what we have seen with the data. So really, this is just to highlight that gene panels are certainly helpful and often more accessible for our patients, but we have a lot to learn about the genetic etiologies of hydrops, and we know that these are limited by the genes included that are on the panels. I'm going to skip this one in the interest of time, but if anyone is interested, I'll just point you to this study, which we published a couple of years ago that focuses on the cost effectiveness of exome sequencing as compared to gene panels, which came out to show that exome sequencing was the most cost-effective strategy in any scenario, including scenarios with and without the option to terminate a pregnancy. And then I had alluded to this a little bit earlier, where now we are pivoting a little bit more to genome sequencing as this becomes more available in the prenatal space. And there's been some studies that have been published on genome sequencing for hydrops in particular. But what has been really interesting to see is that nearly all of the variants that have been identified on genome sequencing, we would expect to have been picked up by exome sequencing. And so really, again, the variants lie in those exonic regions primarily, where we understand the etiologies of human disease better. And so this slide I put in just to give an example of one of the studies that has been published about genome sequencing with hydrops, where they reported in this, it's a smaller cohort of 23 cases, they reported a diagnostic yield of 52%. It's a little bit hard because it's a small cohort, and found many of the same diseases that have been published in other cohorts. But again, I would just highlight that we have a lot to learn about intronic areas of the genome and their contributions to disease. I am getting close to being done. I'm conscious of the time. I just want to emphasize a couple of things here. So hopefully what you've gotten a sense of over this talk is that we have a lot to learn, not only about the genetic etiologies of hydrops, but also about how these cases present in the fetal space that perhaps are different than how they present after birth. And we're really beginning to understand that genetic diseases and how they present after birth are not the same often as how they present in utero. And this is one of the really fascinating areas of research that I think about a lot, which is what is the unique fetal presentation of these diseases and how do we arrive at an accurate diagnosis earlier for our families? I give some examples here of things like an increased nuchal translucency and fetal effusions, like we have been talking about. But again, coming back to thinking about what are the clues in front of us? What is the gestational age at which we are starting to see some of these features? What is the constellation of features? And what do we know about the unique fetal presentation? So I give the example here of RASopathies, where we talked about a case one of a case that had Costello syndrome, one of the RASopathies. We know a lot about how the RASopathies present after birth and a good amount about how they present during pregnancy. And I put a lot of the features here, but I think what's really interesting is to think about what is the unique way that they present in utero. And so again, we saw some overlap with our cases where, we saw arrhythmia in the case that I presented with polyhydramnios and many of these things. But I would highlight that there's some additional things like abnormal posturing of the extremities. For example, contractures is something that we have seen repeatedly in the setting of Costello syndrome, which I think is something that is under-recognized as perhaps a presentation of that diagnosis. And it'll be really interesting with more and more data to understand. Tim, please cut me off if I need to stop. I have maybe a couple more slides.
Yeah, I'll give you 2 more minutes.
Okay, all right. I'm gonna breeze through. I just want to highlight with this slide here really quickly that this is also a really fascinating area of emerging research, which is understanding somatic mutations that can lead to fetal effusions. And I think about this a lot, for example, in our cases where we really expect to find a genetic diagnosis when we do an amniocentesis, and we are just perhaps missing it because we're doing peripheral testing and we're not directly testing, for example, the lymphatic tissue and understanding whether there are somatic mutations that are the explanation for what we're seeing on ultrasound. I put this slide in because I think it is, I don't know if anybody looks at those highlight magazines or how widespread these are, but I used to read these with my kids all the time. And this is one of the analogies that I use for hydrops, which is that, you have a fetus in front of you with hydrops, and on first glance, they look very similar. But when you look in a lot more detail, there's a lot of differences between the cases. And that's the way that I like to approach these cases, is think about what are the unique details that are different from one case to the next, and what is the clue to the diagnosis. So lots more that we certainly need to understand. And I just want to emphasize too that we also have this ongoing trial that is run by Dr. Tippy McKenzie, who's one of our pediatric surgeons, that I can answer any questions about separately, but just to make everybody aware of it, that the whole point of this is to take existing enzyme replacement therapy that is available in the postnatal space and apply it in utero. And so administer in a similar way that we would with IUTs, with the hope being that if we intervene and administer enzyme replacement therapy for inborn errors of metabolism in utero, that we might mitigate some of the really adverse central nervous system effects of these diseases. The preliminary results have been promising. We have a lot more to learn, but if you have a patient with an inborn error of metabolism who is currently pregnant, we have a clear diagnosis. They are enrolling and are enrolling internationally, and I'm happy to answer any questions about it. So with that, I will end and say thank you so much for the opportunity to talk today. It's, again, one of my favorite subjects to talk about, and I'm happy to answer any questions at the end.
Thank you, Teresa, and thanks for your enthusiasm, and sorry for cutting you short. But I see that a lot of people are already putting some questions in the chat, and I really want to leave some time at the end for that. I think that you and Dr. Abbasi have raised some great enthusiasm around in our crowd. We've got almost 200 people online now, so that's fantastic. It's probably one of the best attended VES sessions so far. So that being said, I'm not going to take a lot of time, but I would like to introduce Dr. Nimrah Abbasi. Dr. Abbasi trained at McGill University in Montreal, Canada, and followed that by a fellowship in maternal fetal medicine here at the University of Toronto, where she stayed on and where she's now one of my close colleagues, sharing an office just on the other side of the wall. She's recently completed a master's degree also at the Institute of Health Policy Management and Evaluation at the University of Toronto, with really a focus on quality improvement and patient safety that she's applying here in our unit. Her research and clinical interests focus on improving standardization and quality assurance in obstetric ultrasound, simulation, and other types of training in fetal therapy, and development of local and international outreach projects to improve access and standards in women's imaging. She has recently completed a few studies also looking at our cohort of fetuses with pleural effusions and looking at their long-term outcomes and complications that can sometimes occur in these babies and fetuses. So she's really the expert on the topic of the management of fetal pleural effusions, and that's what she is going to talk about. Thank you very much, Nimrah. Go ahead.
Thanks so much, Tim. I just want to confirm that you can hear me and see my slides. Okay, perfect. So thanks so much for the kind words and the introduction. It's a real honor and privilege to be here. So thank you to the ISPD organization committee for inviting me to speak. So I have no disclosures. I'm hopeful that over the next 25 minutes or so, we'll talk about the pathophysiology of pleural effusions, distinguishing between primary and secondary causes. How do we diagnose these conditions prenatally by ultrasound? What is the role of prenatal intervention? What the prenatal therapies are available? And I'll go over what's available from the literature with regards to perinatal and long-term outcomes. Unfortunately, though, this is a limited area in our field. And briefly, I'll touch on neonatal management, and particularly within the delivery room, what we should be thinking about. So when we're talking about pleural effusions, obviously, we know these are not very common conditions, but in the fetal medicine world, it's something we come across not uncommonly. And there's sort of a distinction between primary and secondary effusions. Primary effusions are related to a lymphatic abnormality, or what we call a congenital chylothorax. But this should be understood that this is really a diagnosis of exclusion. And it's really important when you see pleural effusions that you look for other causes. So things like other structural or genetic anomalies, congenital infections, and then really similar to the workup of immune and non-immune hydrops, you are again looking for other causes of anemia or other causes of hydrops. The prognosis generally depends on the presence of additional genetic and structural anomalies, how the hydrops persists if it does, and when these fetuses or these infants go on to deliver in terms of timing, because prematurity plays a huge impact in how they do overall. When we talk about ultrasound assessment of pleural effusions and how to diagnose them, so first of all, when you're looking at a pleural effusion, what you should recognize is that a pleural effusion is going to appear like a sort of a bat wing and sort of floating within this pleural cavity within the fluid around surrounding it, so very much like a bat wing, and that should be contrasted with a pericardial effusion, which is going to be really pushed back and not freely floating as such. And so on the right hand here, you see a pericardial effusion. On the left, you see a pleural effusion. So it's important to make that distinction because, of course, the causes are completely different. You should also be looking to see whether it's unilateral or bilateral. You should be sort of distinguishing the degree of mediastinal shift, whether there's other problems for the baby or other pathology that you see on ultrasound. And also in about 60 to 70% of babies, they will also be hydropic. We sort of tend to distinguish hydrops related to pleural effusions by sort of comparing the amount of content of fluid we see within the chest. And typically when it's related to pleural effusions, you'll see more chest accumulation of fluid compared to other compartments. It should be isolated. We shouldn't see anything else. And the other thing is paying attention a little bit to the distribution of the edema. So here, you'll see that the fluid is kind of all throughout the body or the subcutaneous tissue, but as you move up into the chest, the edema is much more concentrated in the upper chest and head and neck area. And so this would be more consistent with a pleural effusion causing hydrops rather than other causes. And that we often will use that in practice to help guide us to understand whether the primary pathology is the effusions. In terms of other things that may come up, so these are just examples of cases that were referred to us for pleural effusions. So this patient was referred to us with right-sided pleural effusions, but after some additional imaging, we saw obviously that there was more going on here, and you can see part of the liver sitting in the chest. This, of course, is a right-sided diaphragmatic hernia. And so not just an effusion, but obviously much more to speak to the patients about than just fluid accumulation. This was another patient who was referred to us with suspected pleural effusion. This, in fact, was a right atrial aneurysm, so not just a simple effusion. This was another case that was referred to us for an effusion and for treatment, but you can see here that these are the lungs sitting above, and below the diaphragm, there's actually a lesion there, which represents an extrapulmonary sequestration, which again is a different type of pathology. And in about 10% of cases, they will have an associated pleural effusion. So it's important to make sure that there isn't other pathology, but particularly paying attention to the thorax, because there may be other things that are going on, and the fluid that you're seeing may be other related to other pathology. So as I said earlier, the workup is very much similar to the workup of a hydropic fetus in many ways. You are looking for any causes of fetal anemia or inherited hemoglobinopathies and things like this. But it's important to recognize that anemia typically will present with ascites first. So if you just see pleural effusions and some hydrops, it's unlikely to be anemia, but it is part of the workup. You do look for congenital infections by doing maternal serologies. You want to do a detailed anatomical survey for the fetus, looking for additional structural abnormalities, stigmata of torch infections, looking for middle cerebral artery Dopplers for anemia screening. You also want to have a detailed echocardiogram, so get your cardiologist to look at the heart, because we know many cases of hydrops are related to cardiac pathology. And you want to think about doing genetic testing, and we'll touch a little bit on this in terms of pleural effusions and what to think about, but common things like aneuploidy, and as you heard about Noonan syndrome and Rasopathies. You may also think about doing a diagnostic thoracocentesis or an amniocentesis. And theoretically, we talk about doing a cell count on the pleural fluid for lymphocyte count. And if it's a high lymphocyte count, this may be more suggestive of primary pleural effusions. In practice, we find that a majority of the effusions will actually show high lymphocyte counts, regardless of the etiology. So it's not so helpful in practice. And you could also send off that sample off for genetic testing and infection. So those are kinds of the main things to think about in terms of testing when you see a pleural effusion. When we talk about genetic testing, you may be thinking about aneuploidy as early as the first trimester as the cause of this, with an increased nuchal translucency. Here's a classic increased NT hydropic type picture with small pleural effusions, which is really the not the most important finding here, but something you may see. There's very significant jugular sacs, so of course, and a hypoplastic nasal bone, and this is a very classic sort of severe Down syndrome in the first trimester. You may also see sometimes in the first trimester these very large cystic hygromas again with very significant pleural effusion and ascites. And then if you look around, you might see a few other things. So if you look at the heart, you see here that the left ventricle looks a bit smaller than the right ventricle. The aorta looks a bit smaller too. This is a female fetus. Of course, this is a Turner syndrome. So we should be thinking about common things, and many of these common aneuploidies may present in the early pregnancy with very significant edema. What about other conditions? So we heard a lot about RASopathies just now. RASopathies are dysregulations in the RAS-MAPK signaling pathway. The common conditions that we think about are Noonan syndrome, Costello syndrome, cardiofaciocutaneous syndrome. The challenge with these conditions, though, is that they have many overlapping prenatal features, and particularly related to lymphatic abnormalities or lymphatic dysplasia, meaning they can often have fluid collections like pleural effusions, nuchal edema, subcutaneous edema. So they may be a little bit difficult to distinguish prenatally, but is definitely something to think about when we see fluid buildup and hydropic fetuses. This was a recent paper from the Netherlands looking at the role of RASopathy testing with next generation sequencing using a 14-gene panel for RASopathy testing in fetuses with different ultrasound findings, essentially focusing on edema, so high NT, jugular sacs, effusions, ascites, polyhydramnios, cardiac or renal anomalies, and these fetuses all had normal microarrays. The RASopathy yield was quite significant, actually, and about 9% of these fetuses had pathogenic or likely pathogenic variants. And a majority of these patients had either pleural effusions or hydrops. So it's important, again, to think about the testing for RASopathies when you have this fluid accumulation. In terms of Noonan syndrome specifically, because we talk a lot about this, particularly in the context of pleural effusions, if you look at sort of the classic neonatal appearance, there's this sort of thick nuchal fold or nuchal edema, hypertelorism, sort of this deeply grooved philtrum, the broad nose, and so on. So very classic facial features, and also the edema that we talk about. But prenatally, the phenotype has been well described and more recently also published in prenatal diagnosis. Kind of stays pretty persistent over the years in terms of what we can see. So it's really mostly nuchal edema, increased NT in the first trimester, persistent nuchal fold in the second trimester, fluid buildup like effusions, ascites, cardiac or renal anomalies, polyhydramnios, and some very typical facial features that we may be able to see prenatally as well with some detailed imaging. In practice, in our experience, of those fetal pleural effusions that required fetal intervention, which we'll touch on a little bit later, 5% of our cases were actually found to have Noonan syndrome, so not an insignificant proportion. And in our practice, when we do see pleural effusions, we do proceed with RASopathy testing as well after a normal microarray. So thinking about additional genetic testing. So as we heard in the previous talk with Dr. Sparks, when you think about microarray analysis in the context of hydrops, but also in the context of pleural effusion in recent reviews, it doesn't seem to add a lot above a basic karyotype. There have been studies that showed maybe to 7% in studies with any fluid accumulation, but it may not always explain the whole picture, as you heard previously. If we look at more detailed lymphatic anomaly genes testing in the context of hydrops or clinically significant edema, there may be a significant yield as well. These are smaller series, and when we talk about clinically significant edema in the second series, what they were referring to was any infants that required prenatal intervention or postnatal intervention. And these are all infants with sort of normal microarrays. So again, there may be a role for more targeted lymphatic anomaly type genes in this population as well. When we talk about exome sequencing, and you heard a lot about this, and so I won't go into this in too much detail, but what we did say was in Dr. Sparks's work, which demonstrated that about 30% of hydropic fetuses were found to have abnormalities, mostly related to RASopathies, and about 10% in single effusion. So we can definitely extrapolate some of that data to pleural effusions. Smaller series, again, have demonstrated about 7 to 17% yield of exome sequencing, but these were very small case series. So I think definitely something that we're getting more information on, and probably will hold a role in the future as we understand better about exome sequencing for this pathology. when we talk about, once we've sort of done our best prenatally to sort of exclude other pathology, and we're really thinking that this is a primary pleural effusion, what are the outcomes and what should we be telling parents? So in a small percentage, these pleural effusions will resolve, but they're typically small. They're typically unilateral, and there's typically no hydrops. So it's not going to look like the effusion that you see on the screen. This effusion on the screen is a very significant pleural effusion with very significant mediastinal shift. And what will happen is that you will get here pulmonary hypoplasia. You will also get progressive hydrops because of the cardiac compression and the venous drainage compression as well. You'll also get esophageal compression and polyhydramnios. So these babies will be very sick, and the survival, unfortunately, is not optimal, and there's a high risk of mortality. So it's really in this population we think about prenatal intervention and what can we do to improve the outcome. So there was an initial report by Charles Rodak, and this was really the beginning of fetal therapy for prenatally diagnosed pleural effusions in the New England Journal of Medicine in the 1980s. They had 8 cases where they introduced a pleural amniotic shunt, which a little drain essentially going into the pleural cavity that drained into the amniotic sac. So it was a drainage of the fluid there. And among their cases, they had, and they used the Rodak shunt, or which is now called the rocket shunt. And with this small series, what they demonstrated was that there was about 60% hydrops resolution, about 3/4 survived. Among those that in terms of the respiratory difficulties, there was none in 5 of these 8 infants. And among those that did not survive, they didn't see any lung re-expansion despite shunting. So this was really the beginning of the understanding of, you know, what could we do prenatally to help the outcomes, and this supported the role of pleuroamniotic shunting to improve survival, and particularly in hydrothorax or pleural effusions when there weren't other congenital anomalies. Many years later, many decades, many studies, many centers, we kind of see similar results from this initial Rodak paper, and what we see is that in overall, when we look at all the centers, is about of pleural effusions, about 70% of them will be hydropic. With intervention with these shunts, about 60% will have resolution of hydrops. And if we look at survival, the survival is better among non-hydropic fetuses, reaching close to 90%. And among those that are hydropic, it's about 50%. So not perfect, but definitely better than without doing intervention, particularly when you're in the presence of hydrops. When we look at our own data here at Mount Sinai Hospital and sick kids, and we've sort of over about 200 cases that we've sort of put, or close to 200 cases that were put together. We typically will shunt fetuses when we see non-hydropic, non-immune hydrops with primary pleural effusions based on some of the criteria that I was talking about earlier, or we'll shunt babies with isolated pleural effusions that are occupying more than 50% of the chest with significant mediastinal shift or rapid increase in size, no additional anomalies, and after multidisciplinary counseling, and if the parents are willing for intervention, we will offer them shunting. In this series of almost 200 cases, like I said, 60% were hydropic. The overall survival was close to 70%, but there was a significant difference between hydropic and non-hydropic fetuses. The survival was almost 80% in non-hydropic fetuses compared to 56% in hydropic fetuses. What was also important to recognize was that there was about 10% chance of in utero fetal demise, and almost 25% or 22% neonatal demise, which is also quite significant and important to remember when counseling patients. And we'll touch on a little bit about what the neonatal demise may be related to and some of the possible etiologies. The risk of preterm rupture membranes in this context was about 6%. There was a little bit of an earlier gestational age at delivery, so late prematurity on the average gestational age was about 35 weeks. And on multivariate analysis, the most important predictor of outcomes or survival, and particularly normal neurodevelopment, was the gestational age at delivery. If we look a little bit more carefully at the pregnancy characteristics and the outcomes of shunting, some of the factors that we found that were important in predicting outcomes were, did the hydrops resolve or not? How much time did we get between shunting and delivery? And also, like I said, when the fetuses went on to deliver, and that was also helpful in determining how these babies did in terms of survival, near developmental impairment, compared to those that had impairment and those that did not survive. So important factors to consider as well when you're offering intervention. This was a case of ours that that was persistently, the pleural effusions remained despite shunting. So you can actually see the shunts sitting out in place here, draining, but still a significant pleural effusion. And this baby had multiple shunt insertions. The other thing you can also notice is when you look down, you sort of see some bilateral hydronephrosis as well. And actually, this infant was found to have Noonan syndrome on further testing, and resulted in a neonatal demise in the early, shortly after birth. There is a recent small series looking at the volume of exome sequencing in fetuses undergoing fetal intervention. And this is a retrospective series which looked at 18 hydropic fetuses that underwent shunting. In their series, the survival was about 70%. And among the survivors, all of them had normal exome sequencing. In the non-survivors, they found that about 16% had pathogenic variants. So among the whole cohort, about 16% had pathogenic variants. And that was actually, out of the non-survivors, 3 of them had those changes. So quite significant. If they had used that data prior to intervention and use that to select for fetal therapy, the neonatal survival would actually have increased from 72 to almost 90%. So again, it may help us with selecting those that may optimally actually benefit from fetal therapy. The other important point to highlight when you're counseling patients is that although we do our best prenatally to isolate additional anomalies, both genetic and structural, there is still a significant risk that you may find something after extensive workup. So in our experience, about 30% of those so-called isolated pleural effusions were found to have additional findings after pre and postnatal workup. And in those cases, about 50% of them resulted in a mortality either in utero or postnatally. So important points to remember. The other thing we found was that among these additional findings, 70% of the cases were actually found, findings were actually found postnatally. So I've just listed some examples here of other syndromes that kind of came up or came to light postnatally. Some of these you may suspect prenatally, but many of these you cannot know until the baby is born. So there is a lot that we don't know. And it also highlights the need for very detailed examination with the geneticists and the pediatricians postnatally. And prenatally, but also, of course, postnatally. And so the other thing that came up in our series was that there was no fetal infections that came up to cause the pleural effusions, and many other series have demonstrated that as well. So probably the torch workup is not so relevant, but we often do it anyways, just for completion, but probably not responsible for many cases. What about neonatal morbidity? So we know when the babies are born, what happens, and I sort of talked about that risk of neonatal mortality. So the important things to remember is that there is an increased risk of prematurity. Over 50% will need a postnatal chest tube. And these are basically based on data from all of our fetuses that were treated prenatally and delivered at our center. So we, of course, are talking about a more severely affected population that have undergone prenatal intervention. But still important to recognize that also many of these babies will require ventilatory support. About 25% needed inotropic support. Almost all needed TPN. And quite significant lengths of stays in the NICU. And a quarter of this population actually resulted in a neonatal demise. And when we looked at the causes of the demises, about 25% were related to pulmonary hypoplasia. These neonatal morbidities highlight the importance of having these infants delivering in level 3 NICUs with availability of pretty complex and standardized care, particularly for ventilatory support, as well as the nutritional protocols and so on that can be quite complicated for these infants until they make their recovery and make their time out of the nursery. The other important question, and often will come up with many fetal anomalies, is with families, is discussing neurodevelopment and what does this mean for the child long term. So there's not a lot of data on this. In our experience, when all of our children do go on to have neurodevelopmental follow-up, and this is basically data based on 2 to 5 year follow-up, and in terms of looking at neurodevelopmental impairment among, of course, our live-born infants, which were about 120 cases. In terms of overall normal neurodevelopment, there was about 100 cases, or about 85% that had normal neurodevelopment. So fortunately, the majority, about 8% had severe neurodevelopmental impairment, as defined on the slide here. And what's also important to distinguish is that when you look at compare isolated versus non-isolated pleural effusions, there is a significant difference in neurodevelopment. So about 90% normal neurodevelopment in isolated cases and almost 50% neurodevelopmental impairment among the cases that had non-isolated pleural effusion. So again, highlighting the importance of a very detailed workup pre and postnatally for these kids, and also long-term follow-up to see how they're doing, and intervening and supporting them if there are other issues that do come up in terms of neurodevelopment. So just to summarize perinatal and long-term outcomes from the best that we know in the literature, and there is a lot lacking, but we have to, when we're counseling families, we should be talking about the risk of prematurity, with particularly in the context of the more severe forms that are requiring prenatal intervention. We should also be thinking that, or remember that there is a possibility of additional diagnoses. In our experience, it's been up to 1/3 of cases. So, families need to be aware of that as well. There is a significant risk of neonatal demise in the postnatal period. So we have to be thinking about delivering them in the most appropriate setting with the availability of the pediatric and NICU expertise. There is some data looking at supplemental oxygen and susceptibility to infections and asthma in the early years of life. Again, the data is limited, but there does seem to be maybe some increased risk of this. Fortunately, the majority are not going home with oxygen at discharge, but that may be a possibility too. Majority will have normal neurodevelopment, but remember that this is also dependent on the gestational age at delivery, as well as the presence of additional genetic and structural abnormalities that may impact the neonatal course and, of course, the long-term course for these children. Again, the data is limited, and this really highlights, when you look at the literature, the need for multi-center registries and long-term follow-up programs for, as in many other fetal anomalies, and for this one, it is particularly important as well. Just a few words on fetal shunting, just the technical aspects for those of you who are interested. This is our typical setup that we've used in the past. There are many different shunts available. We've preferred to use the rocket shunt in the past, but unfortunately not so much available anymore, and mostly use the Cook or the Harrison shunt. And many other centers may have experience with other ones as well. And there is not really one proven to be better than the other, whatever you're comfortable with. These procedures are generally performed under local anesthetic and IV sedation. So it's a minimally invasive approach. We do give peri-procedural antibiotics. We give steroids at viability for lung maturity. We don't typically paralyze the fetuses because we actually use the fetal motion to our advantage to help us insert the shunts. And so, particularly if we're doing bilateral shunts, having the fetus move actually helps us to rotate the fetus. We sometimes will put in a bit of extra fluid if we need to, but we will drain the extra fluid at the end with an amnio reduction. We perform weekly ultrasounds thereafter to make sure that the shunt is in place, the effusions have resolved, and they haven't reaccumulated, and so on. When you're going to put in a shunt, you also need to be aware of the complications as well. Of course, we talked about the risk of prematurity. In our experience, like I said, the PPROM risk was about 6%. There is a risk of preterm delivery, and majority are sort of a late prematurity. We should also be cognizant about the risk of blockage of shunts, migration of shunts, either into the chest or outside of the chest into the amniotic space or cavity. Hemorrhage from often the placental edge or abruption, membrane separation, infections. There are some rare shunt-related, complications like iatrogenic gastroschisis, constriction bands, core trauma, or lacerations. So fortunately rare, but things that we should also be aware of as well. When we looked at our shunt blockage, our complications, but shunt blockages as well, we found that to be about 5% risk of shunt dislodgement, I should say. Some of them were actually into the chest and others were outside of the chest. 1/4 of these needed to be reshunted. We've also had some long-term follow-up with infants with intrathoracic shunt dislodgement, so those that went into the chest itself. And the majority of these actually are pretty inert and they don't cause any problems, and you can leave them without any major consequences. The ones, though, that show mediastinal involvement on postnatal imaging, they do have to be removed, and typically these can be removed with a minimally invasive thoracoscopic approach. But again, something to be aware of as well. So given these complications with shunts, we may want to think about it, well, is there anything else we can do? So similar to postnatal life, there is something called pleurodesis with OK432, which is derived from group A strep. And basically it incites a very significant inflammation, and it's been reported for massive, large effusions, hydrops, and also being used early on in gestation with success. The other thing to remember is that once if it collapses the pleural cavity, this might actually be a complete resolution, and the infant may not need treatment postnatally. So that's something attractive about it. And in some series looking at survival, comparing shunting to pleurodesis, the outcomes have actually been pretty similar in both hydropic and non-hydropic fetuses. But it's important to remember that the pleurodesis experience is quite limited in terms of numbers when you compare it to shunting internationally in terms of the fetal therapy centers. There were some reports of very significant adverse events. So one maternal death, which was related to an amniotic fluid embolus. However, this occurred about 8 weeks after intervention. So we may wonder whether this was something just coincidental or truly related. There was one neonatal renal insufficiency case, again, in a fetus who had some renal anomalies on ultrasound prior as well. So again, may not be entirely related, but it hasn't really gotten that widespread use, probably because of these significant adverse events that have been reported. Just a few final words on delivery room management. So again, remembering particularly the ones that are undergoing fetal therapy fetal therapy should be delivered in a tertiary care NICU. Right at delivery, these shunts should be clamped because we don't want pneumothoraces. If there's no pleural effusions on the most recent imaging prenatally, you can remove the shunts, you can put an off-site dressing and do a chest x-ray to look for fluid and pneumothorax. The pediatricians will obviously do these things are accustomed to doing these things. When we talk about those that are a bit more persistent, so those effusions that are kind of sticking around despite intervention, they may have a more difficult resuscitation course. They might need aspiration in the delivery room. They may need more treatment for persistent pulmonary hypertension, inotropic support. You may unclamp the shunts until you can insert a chest tube, for instance, and that might help with some of the drainage in the interim. These infants will be transferred to the NICU, particularly the ones with the more challenging resuscitation, of course, where they may need respiratory and cardiac support, and nutritional support, where we have to often modify their diets, often just things like medium chain triglycerides for them to reduce their lymphatic output. They may need infection screen or monitoring for infection because the infection risks do go up with very high output states. They may also have a thrombosis risk as well because they lose a lot of their antithrombin with the high output state again. And they also need detailed examination and additional imaging as well to looking for additional pathology. And for refractory cases, may need surgical management or embolization through radiology. So can be quite significant course as well postnatally for some of these infants. So just for a final summary of what we've been talking about. So when we are confronted with pleural effusions, we should be thinking about some major, some main questions that we should be asking ourselves are, is this isolated? Is this unilateral or bilateral? Is there hydrops? Is there significant mediastinal shift? And is this kind of expanding rapidly? And if these are the questions we should be thinking about fetal intervention, either in your center or a center that performs them, if particularly in the population that do undergo fetal intervention, we should be thinking about delivery planning in a level 3 NICU because of the significant risk of prematurity, neonatal morbidity and mortality that we touched on, and also for a detailed workup for possible additional findings that may come up postnatally. And thinking about as well integrating these children into long-term follow-up programs for respiratory and neurodevelopmental outcomes. So I will stop there. I'm happy to take any questions. Thank you so much for your attention. And I appreciate, again, the invitation.
Thank you very much, Nimrah, for that very comprehensive overview. And we do have about 15 minutes left for questions, and there is definitely quite some questions from the audience. Now, I'm maybe going to start with a few questions for Teresa to let you catch your breath a little bit, Nimrah. And I think that Teresa has had some time to catch her breath in the meantime. So I think that one of the questions that came up from different people is a little bit about, when do we do exome sequencing, and what are really the explanations in the indications, in fetuses with effusions. If you see a thick NT, when are you going to offer whole exome sequencing? Is that when the NT is above the 95th percentile? Is that above 3.5 millimeter? Is that if you call it a hygroma? And what about later exome sequencing?
That's such a good question. What I would say is that in our experience with the big nuchal translucencies or cystic hygromas that present earlier in the pregnancy, most typically, historically, we included cases that were at least 3.5 millimeters. And the purpose of that really was to understand the diagnostic yield. What we have seen over time is that in isolation, if there are not other effusions or other anomalies in association with a nuchal translucency that is maybe 3.6 millimeters, somewhere just above that cutoff, the yield is pretty low. So we have shifted a little bit. What we currently offer at our center is if the nuchal translucency or cystic hygroma is at least 3.5 and there's something else, like another anomaly or another effusion, we will offer microarray and next generation sequencing with genome sequencing because we're able to do that at UCSF. If it's isolated, we tend to lean a little bit more to it being more than 5 millimeters because we know that the yield is just greater for those cases. I do think that this is an area where we need more guidance, though, because we're all kind of sort of making it up with the data as we go. And that's where we have settled with our institutional practice for those cases. I think it's more clear later on. And, this is a really interesting area that I think about a lot for our patients. Like if they come in for an anatomy ultrasound at 20 weeks and we diagnose the hydrops, we know based on the data with both of the talks that, karyotype is going to give us an answer in, somewhere 10 to 20% of cases. Microarray is unlikely to have a significant incremental yield. And so particularly for cases that we think are really likely to be a single gene disorder, we will talk to patients and have the conversation of, do we send the microarray, wait for that result, and then send the genome sequencing? Sometimes we send them concurrently if we're really suspicious of a single gene disorder. And that, again, is another area where I think we need more guidance as a field with which are the cases should we be just sort of skipping ahead and offering the testing for single gene disorders particularly when we're more suspicious of those.
Yes, that's great, and thanks for gathering all that data, because I think that's one of the big problems that we certainly have here in Canada, is that our whole exome sequencing is basically controlled by the government, and we need approval for whole exome sequencing, and so the more data we can gather on which populations have the highest yield, the more the government is going to be likely to allow us to do the whole exome sequencing. And indeed, with us, they will only for now allow it if there is more than one abnormality. So just an increased nuchal translucency, for example, will in many cases not be approved. In line with that a little bit, what are your timelines for whole exome sequencing and whole genome sequencing? Because obviously the relevance of a test is often also related to how soon results will be available, and what do you offer, or what can you offer, and what is your field that most labs can offer?
Also a really important question for patients who are trying to make decisions quickly. So it does vary a little bit by lab. What I would say is that when we're talking about exome and genome sequencing, I think there was a question too in the chat that I saw about why does exome sequencing take a little bit longer than genome sequencing? The reason for that is in the preparation to do the test and in the library prep that goes into the setup for actually completing the exome sequencing, which is why that takes longer historically than genome sequencing. For us, we do all of our testing through the Genomic Medicine Laboratory at UCSF, which I think probably has very similar turnaround times from what I have gathered for other commercial companies. We are a little bit conservative with our patients with telling them the turnaround time because sometimes things unexpectedly take longer, and we want to make sure we're giving people a realistic explanation. For exome sequencing, often our lab and commercial labs will quote somewhere around 2 to 4 weeks for a stat case for, we need the results quickly with an ongoing pregnancy. Sometimes the non-continuing pregnancies can take a little bit longer because the priority is given to the continuing pregnancies. With genome sequencing, the results are typically faster, and we see turnaround times more on the order of 1 week in cases of trio genome sequencing to 2 to 3 weeks in cases where we do a proband first approach.
Yeah, that's excellent, and especially if you can run both tests in parallel with a microarray, then you really get fast results and can give couples time for making decisions. A few questions for Dr. Abbasi. I think that your presentation on shunting was very, very clear, and a lot of people want to hear a little bit about alternatives to shunting. And if you have any experience with pleurodesis, whether propranolol is an option as has been tested in postnatal lymphatic malformations, whether you would offer sequential thoracocentesis if you can do shunting. What are your thoughts about all these alternatives?
Okay, lots of good questions. So for maybe I'll start just with the serial thoracocentesis. So, you know, initially in the experiences, this is what was done before shunts and so on became into common practice. The problem, though, is that they will inevitably recur. It could be used for diagnostic purposes, but if you don't have access to a shunt and that's all you have and you can't get them else to anywhere else, because really what you want is sustained drainage, so the lungs have an opportunity to expand and develop. But if you just keep draining it and it keeps reaccumulating, you may not get that pulmonary development that you want. But if you really don't have access and you can't get someone to a place where they could do it, which I've gotten questions about this too overseas and so on, I think the drainage is probably a reasonable idea, particularly right prior to delivery, because it really helps resuscitation for the pediatricians. And it's easier, actually, if you're comfortable doing this, it's easier for you to do it than often the pediatricians, because it's a little bit more challenging postnatally as well with the infant in terms of just the technical aspects. So I think it does have a role in limited settings, but it just isn't a long-term solution. And every time you do an intervention, you have a risk. I think, so there's some reports for propranolol and pleurodesis and these kinds of things. I think the pleurodesis data is interesting, and I think it's promising because you could do it very early on. We know with the early shunts, so you often get them dislodged. They're just technically a bit more finicky. So the pleurodesis is promising, and also that, you know, when you do it, you might actually have a permanent solution. Again, the data is limited, and with these few adverse events, we just, you know, the studies kind of, I guess, got halted a bit, which understandably so, but I think it has potential. And the postnatal literature does do, you know, is quite consistent with this, using this technique. Propranolol, there's some reports as well, and anecdotally, I've heard of some cases which have been treated prenatally. But yeah, I don't have any experience. Again, I don't know that there's much data on it as well. But all interesting questions and probably have some potential as well somewhere along in the scheme of treatment prenatally.
A question from Dr. Hack regarding the inclusion criteria used for thoracoamniotic shunting in our center. So you said, yes, obviously we will shunt fetuses with hydrops because of the effusions. But you said that we would also shunt those with unilateral infusions where they're really large and where they're taking up more than 50% of the chest. Her question is really how do we judge on whether it's taking up more than 50% of the chest? Do you use any specific measurements for that?
Yeah, it's a good question. I think it's more of a subjective assessment. I showed sort of an image where the heart was completely pushed and the whole nearly three quarters of the chest was filled with fluid. I mean, it's just it's really a subjective assessment, and if you feel that the fluid is taking up majority of the chest, I think it's reasonable to drain. And also it's the rapidity with which you see the fluid build up. And that often could be a sign that things are moving along. So we follow those ones pretty closely, like on a weekly almost basis, if we think that they might do something. And it's also sort of the trend over time, but not necessarily a specific measurement. It's a subjective assessment.
And then maybe a question for both of you from Dr. Mayen. So she has some questions about the postnatal follow-up and the longer term follow-up of these kids, because obviously that's something that parents worry about. Is yes, we may be able to treat the hydrops, but what is this going to mean in the long term for my kid? Where we do have some reassuring information. What's the longest postnatal follow-up that we have available, and do we have really follow-up till adult life in these cohorts? Maybe Nimrah, if you want to go.
Yeah, I'm happy to start first. So for pleural effusions, it's very limited. There are some long-term follow-up studies, but quite variable in terms of how much they're followed up to. Most of them are kind of in the early childhood. Most usually neurodevelopmental follow-ups, pediatricians will say at least get them to school age, so you know what's happening in school and disabilities and learning disabilities and things like that. So yeah, it's very limited and it's not standardized. I think, and when you look at even for pleural effusions in terms of respiratory follow-up, even that is often just into childhood, and these are small series, so I don't think it's standardized. And I think at least until school age, at minimum, it would be ideal. But I think for any anomalies, fetal life, this is something we should be thinking about. But
I completely agree. I think this is an area where we need a lot more research. There is a little bit of information that exists, but again, I think we really need that longer term data that's collected prospectively. I think there, have been some attempts with retrospective looks at this, which introduces some bias, right, with who ultimately makes their way into those studies. And so I think we really need a lot of prospective work that's going to follow patients over the long run. It's one of the things that we are trying to do with our cohort, where our goal is to follow them until at least 5 to 6 years after birth for those that live after birth. But we certainly need other cohorts with other patient populations because these are rare diseases and we need a lot of data.
And then maybe one last question to wrap it all up. And there is lots more. You guys really spiked some good interest out there. Thanks for that. But we will need to wrap up. So one last question is, what about the future? We've got a question here about a patient who presented with recurrent bilateral pleural effusions, and who did not get testing done at that time when the patient when the fetus or the neonate passed away, and they're now presenting for preconception counseling for next pregnancy. What would you advise there? Thinking in the field of carrier screening, invasive testing early in pregnancy, follow-up during the pregnancy, what would be your recommendations there?
Go ahead, Nimrah. I can follow.
No,
I saw you
starting.
starting.
I was going to say, I think this is a good question for Teresa.
Okay, I can go. Sounds good. I think these cases are hard, right? Because I think this happens a lot, unfortunately, where we have a worrisome history and, maybe at the time that more expansive testing was not available or wasn't accessible to the patient. One thing that I would suggest exploring in those cases is if there's any residual DNA that's remaining. Sometimes there is, surprisingly, in these cases, especially if they were more recent. And we have done this for a few families that have come to us with a similar history and have called the labs or the centers where the patients delivered, and there has been tissue that we have been able to send for microarray if that has not previously been done, and also for exome or genome sequencing. I think in the absence of that, it's hard, right? Because we're suspicious of a genetic etiology in those cases, and I think we have to be on the conservative side with how we establish a surveillance plan for those patients, and think about a testing approach. But I think until we have a phenotype there, I think we're a little bit stuck in a subsequent pregnancy with what we're able to offer. At least I would say in the United States, I think most centers would offer, a karyotype or a microarray in the absence of any phenotype. I think when we talk about testing beyond there, until hopefully there's not a recurrence of the pleural effusion. But, in the absence of that, I think further testing is going to be challenging. So I usually encourage families to think about testing any remaining tissue that exists and take a really good family history, because sometimes there's more in the family history. And then also Tim mentioned expanded carrier screening, which I think is a very important point. And it's something that we can offer to families in this situation as something to cast a little bit of a broader net. I would say it often doesn't necessarily give us an explanation, but it's something that allows us to be more comprehensive in the evaluation.
I would just add, in practice, we get a lot of these situations and we just don't have a lot of information for families. Unfortunately, even when we do the testing, whatever we can get, if we get samples or whatnot, but we would just offer them ultrasound screening as well. So we often will offer them an early anatomy look, and a lot of time it's just for reassurance, but I think it's also helpful. And then of course the anatomy, and then serial monitoring over the course of the pregnancy for recurrence, because there isn't a lot we often can tell them, unfortunately, and which is distressing, but at least there's some opportunity for surveillance.
Yeah, I think that's an important point. I think that a lot of these effusions will happen only in the third trimester, so they may not be there at the time of the anatomy ultrasound. So longitudinal monitoring, I think, is really important. Often mainly for peace of mind, but sometimes you will pick up something late in the third trimester. Good. With that, we're going to wrap up because we're done for time. This concludes this third session of the virtual education series for this academic year. I really want to thank everyone for joining us today, and a particular thank you to our speakers who gave fantastic talks, and stirred up a lot of discussion. The presentation was recorded, and so it will be available on the ISPD website in the next few weeks for people who want to have another look at the slides. Certificates of attendance will also be sent out by email in the next 15 business days, so in the next 2-3 weeks. So if you need those, keep an eye on your emails. The next VES session will be on April 17th. At 4 p.m. Eastern time, so later in the day, for North America, certainly, with presentations on fetal infections. We've got a presentation lined up on CMV infection and a presentation on new and emerging infections. So really, we would love to see you all there. This is definitely going to be very, very interesting. I'd also like to encourage everybody to make plans to attend the ISPD annual conference, which is planned in Boston, July 7th to 10th this year. Please try to attend either virtually or ideally in person. I think there will be lots of opportunities to meet the speakers that you've heard at these virtual education series and to network there. It certainly has a lot of added value over these virtual meetings. That being said, thank you again for joining. Have a good rest of your day, and I'm looking forward to seeing you all at the next sessions. Thank you very much.